Hi, good afternoon, everyone. We're at the top of the hour, so we're going to get started. Today, our facilitators, Dr. Sydney Horton and Dr. Thomas Itube, are both first-year fellows in the Child and Adolescent Psychiatry Fellowship here at UT Tyler School of Medicine under the direction of Dr. Taya Johnson. Dr. Horton is originally from New Braunfels, Texas. She attended medical school at West Virginia School of Osteopathic Medicine and completed her general psychiatry residency at UT Tyler School of Medicine. She decided to focus on child and adolescent psychiatry as she enjoys working with children and their families and treating the disorders that are more common to this population, such as ADHD and autism. Dr. Itu is originally from Troy, Michigan, a suburb of Detroit. He attended medical school at Central Michigan University College of Medicine and completed his general psychiatry residency at Baylor College of Medicine. Dr. Itu chose to specialize in child and adolescent psychiatry to learn the skills necessary to treat the family system, as he is particular interest in the complex dynamics with the family that contribute to mental illness. So let's get started, and please welcome Dr. Horton and Dr. Itu.
Okay. Hi, everybody. Thanks for joining today. So I'm Dr. Horton, and we're going to get started. So our topic today is going to be trauma assessment and diagnosis in pediatric primary care. So first, we want to start and let y'all know about how to take a social history, because this is really the key aspect in assessing for trauma disorders and then eventually diagnosing them. So we'll kind of walk through how we usually do it when we first see patients to get a better understanding of what's going on with these kids and families. So something like we like to ask is, who lives at home with this child? This is a good broad question to start with because it lets us know, who's taking care of this child? Is it the typical household where there's a biological parent? Are they living with a grandparent instead? So this can kind of tell us what's going on in the dynamics of the family, and also who has access to this child coming in and out of the home, things like that. So kind of leading into our next question, once we establish who lives at home with this child, if they're living with a non-biological parent, how did this person come to legally care for the child? It's really important. So if you have a kid and grandma is the one bringing them in, you want to ask that question, how did you come to care for this child? Because, a lot of times maybe CPS got involved for a reason. Maybe a parent signed their rights away. Maybe a parent passed away. So that can really key us into what has this child experienced. Do they have ongoing contact with their biological parents? Just because they're primarily living with grandma doesn't mean there's not some kind of joint agreement where they still have to have contact with their biological parents. So if maybe one of the parents was abusing them and they still have to see them, they could kind of still be exposed to that abuse when they're not with grandparents. So something to consider. Something else that may come up is, if they're only living with one biological parent, so say it's just mom, just dad, we want to know about the circumstances surrounding this. Are parents divorced? Was that a pretty agreeable separation? Or, what were the circumstances around the divorce? Did they witness any domestic violence with that? Is that why they're separated? Was one parent just never involved? Is a parent incarcerated? So again, this can give you a lot of information about, again, like who's caring for this child and what this child may have experienced. Once you've kind of established that, just go ahead and ask it. Parents, family, they respond pretty well to just being asked, has this kid experienced any neglect? Have they experienced physical abuse, sexual abuse? Just like I said, just go ahead and ask it and kind of be confident about it, because families are usually pretty okay with talking about that and telling you about it. Keep in mind, though, that, those are the common three, and you should probably start with those, but there's other forms of trauma as well. I can think of some examples that I've seen. I've had a couple kids that were in house fires. That was pretty traumatic for them. consider some of your like chronically ill kids that have experienced medical trauma, you know, like our cancer kids, things like that. Bullying even, we need to really be aware of that. I've had some kids that have been physically assaulted at school. Or even, you know, through social media, things like that, the things that these kids are saying to each other can be pretty traumatic and severe. So just like I said, just kind of keep in mind and kind of ask about these things. Then you want to know, you know, do they feel safe in their current environment? Like I said, just because they were maybe removed from that primary parent or whoever that was abusing them, you know, they may still have to see them. So, you know, are they still getting any abuse? Is there still ongoing trauma where they're living? And then you also really do want to know, are they using any substances? Are they engaging in any risk-taking behaviors? You know, all these things that could be safe or unsafe. And you, again, just kind of ask these questions directly to the kid and the family. So, because we need to know that information. Kind of a key with these last couple questions we talked about, you want to try to make an effort to interview the kid alone, just to confirm details, have them expand on things. Just kind of remember that kids and teens may not feel comfortable sharing certain information in front of their caregivers. Maybe the caregiver they came with is still abusing them and they're scared to say that in front of them. Or maybe some things have happened and they just don't feel comfortable saying it. Sexual trauma with peers, like sexual assault with peers, is one where teens may not feel comfortable having the parent know. And you may only get that information if you talk to them alone. Specifically with substance use as well, kids more than likely are not going to say, yes, I'm, you know, using this substance in front of their parents. So with that being said, even if you talk to the families, even if you pull the kid alone, you suspect something might be going on and they may not want, they may refuse to talk to you, or they may deny everything, and that's okay. I still think it's important to make that step because you're just opening a line of communication and building some trust with this patient. I can think of a couple of examples where I've asked kids on a first encounter, you know, have you experienced any trauma, to family and kid, and they both said no. And then several visits later, when I talked to them, they say, you know, actually this has happened to me. So they may feel comfortable opening up at a later visit, but I think it's important to take that first step because they may trust you or know, hey, this is a person that wants to know what's gone on with me. So if they don't feel comfortable, then they may later. So we wanted to kind of talk about the different symptoms of PTSD without, you know, obviously we diagnose by DSM criteria, but without getting too detailed about it. Just kind of remember they have to have exposure to a traumatic event. So, you know, threatened or actual death kind of experiences, injury, sexual violence, are some examples, but remember the other ones we kind of talked about as well. So the symptoms are kind of divided into a couple different categories. So we have our intrusion symptoms. So these are like the thoughts about trauma, the distressing memories that come up, you know, the classic kind of flashback situation. Nightmares are included in this. And then when they're kind of reminded of their traumas or experience a trigger, you know, they get really distressed. Keep in mind the age you're seeing. Older kids and teens sometimes can better tell us, hey, I'm having a lot of thoughts about what I've been through. The younger kids are not going to necessarily tell us, but they're going to show us. So just keep in mind that this still can be diagnosed because if they're expressing the trauma they've experienced through play, so maybe like sexual play with their toys or aggressive play, that we kind of consider one of the intrusive thoughts symptoms because, again, they can't tell us, but they're going to show us. Avoidance symptoms, kind of what it says is, you know, they're really going to avoid thinking about it. They're going to avoid people, places, things that are going to remind them of it. And, you know, substance use can kind of go into this as well because it's kind of the ultimate, you know, I'm going to avoid thinking about or dealing with what I've been through. Cognitive and mood symptoms. So they may have difficulty remembering the event at all, or even just aspects of it. So sometimes if a parent tells you, yes, you know, this is what they've experienced, the kid may tell you no, or things like that. So they may just have problems remembering, especially if it happened at kind of a very young age. This is where you see the negative beliefs or kind of distorted beliefs. So, you know, they feel like it was their fault, they could have done something, or, you know, they don't trust the world, everyone is dangerous, those kinds of beliefs. And this is where you also see a lot of the negative emotions. So, you know, they may look depressed one day, anxious the next day, angry the next day. So, they're kind of fluctuating with their mood and not really staying kind of stable and experiencing those joyful, positive emotions very often. Kind of the last category is the arousal reactivity symptoms, which is a lot of what we're going to see. The irritability, the anger outburst, hypervigilance is kind of that being like on guard, on high alert. The reckless destructive behaviors, so kind of as we mentioned, some of that substance use, the risk-taking behaviors, things like that. Again, problems concentrating and sleeping as well. So that's just kind of some of the symptoms you're going to see in PTSD. Next, we just wanted to go through some psychiatric disorders that can really look like PTSD if you don't take the social history. So we're really going to kind of hit that home of how easy it is to misdiagnose these other disorders when it actually is PTSD kind of driving the symptoms and behavior. So we're going to do this by going through a clinical vignette. So a 9-year-old male presents to the clinic with his grandmother. Grandmother reports that she's receiving behavioral reports from school on a daily basis, and he's barely passing his subjects. She reports that he struggles with anger outbursts and may scream, throw items, or even hit at home and school. She reports that he also hits himself on the head repeatedly when he's upset. He has a lot of difficulty sleeping at night and often can't sleep alone. These symptoms started about 1 year ago. So we're going to start with PTSD first, so we can kind of show you how this fits with the diagnosis, and then we'll kind of talk about the other disorders. So for post-traumatic stress disorder, so you take the social history like we talk about, and then you learn that he was removed from his biological parents by CPS about 1 year ago due to physical abuse and parent substance use, and he was placed with his grandmother for the time being. So there you kind of see you have that trauma exposure, the physical abuse, and oftentimes parents' substance use, while them using this substance necessarily isn't the traumatic event, but you have to think, this could lead to the physical abuse, it could lead to the neglect or having people come in and out of the home that are strangers, things like that. So that's that traumatic event. So in this case, from the vignette, he's experiencing the following PTSD symptoms. So he's got the poor attention and concentration difficulties. He's got the behavioral difficulties that are due to the hyperarousal and reactivity symptoms. So the restlessness, the hyperactivity, and the anger and irritability outbursts. He has mood instability and predominantly the negative emotions like the anger that we were seeing. He has some avoidance, in this case, self-harm, hitting himself on the head, trying to avoid thinking about those thoughts or when those thoughts are popping up. And he has sleep disturbances, maybe it's nightmares he's having, or maybe he's really hypervigilant at night and just has a lot of problems falling asleep because of that. We'll start with ADHD, attention deficit hyperactivity disorder. That's probably the most common misdiagnosis that we see when we get these kids. So, in this case, he's having the behavioral reports from school. He's not passing. So, right, he's having problems behaviorally and academically. Obviously, that kids with ADHD can struggle with emotional dysregulation, have anger outbursts. It's happening in 2 settings, home and school. And we know kids with ADHD can have problems sleeping at night. So if you don't take a social history and this is what you're presented with, you can see how easily it is to start thinking along those lines. So, again, he's experiencing this, could it be ADHD? Well, children with PTSD really do experience symptoms that mimic ADHD, which is why, again, it's so commonly misdiagnosed. So they might experience poor attention, restlessness, hyperactivity, disorganized agitated play, meaning like they're aggressive with their peers or just kind of doing some odd things, intrusive, things like that. And then they have sleep difficulties. So again, as you can see, if you don't have a social history and that's the symptoms you're presented with, you may very well go ahead and diagnose the ADHD. Kind of a note here is that obviously this can be comorbid with PTSD, ADHD, but the timing of the onset of symptoms is really what helps us determine these things. So if the onset of these kind of symptoms occur after the trauma, or worsen around that time, it's probably not ADHD, it's probably the PTSD. Now, kind of a note, obviously we see a lot of kids that have been experiencing trauma and adverse events basically since they were born. So it can be really difficult to firmly diagnose an ADHD in those cases. So really, you just want to educate the parent and say, I know that you're concerned about the ADHD. These can look really similar, but, given the trauma they've endured, we really need to try to treat the trauma first and see what's left over. Oppositional defiant disorder. So kind of maybe you have like a caretaker bringing a kid that's like, oh, this kid's so defiant. So like in this case, he's getting behavioral reports from school. So we kind of assume he's not doing what he's told or, kind of refusing to. And he's having a lot of anger outbursts. So, these kids with PTSD can also appear to have ODD if they present with, the anger outbursts, the irritability, and just being defiant, not doing what they're told. You also want to kind of think about too what trauma they've experienced, because if they were in a traumatic environment where anger was really modeled for them as a way to control their environment, example is to be like domestic violence. So, the abusing parent is obviously using the anger to like control the outcome and like what they want out of their environment. The kid may internalize this and kind of see anger as a way to kind of get what they want and things like that. So when you have a child that's defiant, you really do want to investigate always and see what is underlying that defiant behavior. Major depressive disorder. So in this case, he's not concentrating well. He's having the anger outbursts, the mood instability, hitting himself on the head repeatedly when he gets upset, and having a lot of difficulty sleeping. So as we know in kids and teens, depression often comes with more of an irritable mood than a depressed mood. So he's got that, he's not concentrating well, difficulty sleeping. So, MDD is probably one of the most common comorbidities we see with PTSD, especially in our teens. But also just keep in mind that these depressive symptoms can be mimicked just by the PTSD. So, they'll self-harm to avoid with coping what they've experienced. Again, they're going to present mostly irritable. Affective numbing, that just kind of means that they kind of feel detached. They're not really feeling happy, sad, and they're just not really feeling anything. They may withdraw socially. They're going to have difficulty concentrating, difficulty sleeping. So again, this can really look like depression if you don't have the social history. But again, they can be comorbid. They just need to meet the full criteria for MDD. But again, it can very much mimic it. Bipolar disorder is another one that we commonly see as a misdiagnosis, usually in our older teens, but something you maybe think along the lines of, if he has he's having a lot of anger outbursts, screaming, throwing items, again, multiple settings, home and school, and he's not really sleeping very well. So you're like, well, could this be just, bipolar disorder? So PTSD can really look like bipolar disorder. These kids can have really severe affective, just meaning like mood, behavioral, and like cognitive dysregulation, extreme outbursts of anger. They can even have episodes of silliness, confusion, sexualized behavior, maybe they've experienced sexual trauma, aggression, changes in sleep. So as you can kind of see, it could really look like bipolar disorder if you don't have that social history in place. But something to just keep in mind is that, the overall prevalence of bipolar disorder in kids and adolescents, it's really low. So it's a rare disorder. So psychotic disorders is something to consider as well. So kind of from this, you might think, well, maybe he's just having these like random anger outbursts and there's not really an explanation for it. So the symptoms of PTSD can mimic psychotic disorders like schizophrenia. So, flashbacks, dissociation, they could look like hallucinations to an outside observer, especially if they're kind of happening randomly and the kid doesn't look like they're all there because they're experiencing a flashback or again, kind of dissociating. Hypervigilance can look psychotic as well because it can kind of look like paranoia. They may be checking windows at night, things like not wanting to sleep alone or saying they're seeing things. Again, the sleep issues, like we talked about the affective numbing. So, and like schizophrenia, they're very blunted with their affect. And you can see that in kids with PTSD as well, because again, they're feeling detached. They're not really experiencing a lot of emotions sometimes. And then the social withdrawal. So substance use disorders, primary substance use disorders is another consideration. So again, he's getting in a lot of trouble at school. He's not passing. The changes in mood pretty suddenly. So the anger outburst. PTSD can be misdiagnosed as a primary substance disorder. And like what we mean by that is like, that's their primary diagnosis. Now, substance use can be like a secondary, due to the PTSD. But if you're just not asking a social and you're just assuming that they're just using substances and that's their primary disorder. So drugs and alcohol, like we were talking about earlier, are often utilized as a way to numb, escape, or avoid thinking about the trauma they've experienced. Just keep in mind, children and adolescents, they can and do engage in substance use even at seemingly young ages. A couple of examples I can think of, I've see a couple of 14, 15-year-olds that use marijuana on a daily basis. And, you ask when they started, age 11 or 12. And these are kids with trauma history. Had another 16-year-old from age 15 to 16 experienced sexual trauma. They were using Percocet daily. So that's what I'm saying, don't be afraid to kind of just ask, are you using any substances? A lot of times these kids will probably tell you, especially if you talk to them alone, but just remember that it does happen even at young ages. Anxiety disorders. So he's not passing a subject, meaning he's not concentrating well. He's having the anger outburst, and a lot of difficulty sleeping, and doesn't sleep by himself. So, a child PTSD may just appear to just have an anxiety disorder, like social anxiety disorder or panic disorder. But really what's happening is they're just becoming really anxious and distressed when they're exposed to the reminders of trauma, or when they're experiencing those intrusive thoughts about their trauma. They may even develop phobias, fears, or go to really great lengths to just avoid those reminders of traumas. And that's where you may see those kind of outbursts or defiant behaviors. Now I'm gonna pass it over to Dr. Chu.
Thank you, Dr. Horton. So now we'll be talking about understanding PTSD in pediatrics. So there are some unique features in the DSM, specifically for children under 6, and in the DSM. And that is often due to, like Dr. Horton mentioned, their lack of ability to verbally express their distress. One unique feature to children is actually the type of trauma that's involved as well. So in PTSD in children, what can count as a traumatic event can also be witnessing a caregiver trauma, like an example of witnessing domestic violence, or even learning that a primary caregiver has experienced a traumatic event. Some of the symptoms that can also be unique to pediatrics, like Dr. Horton mentioned before, is including repetitive play involving trauma-related themes, as well as reenacting the trauma through play. You may also see things like behavioral regression, including a regression in toileting and speech, which is why it's important to get a developmental history. You may also see an increase in clinginess, fears of separation, loss of interest in play, withdrawal and emotional numbness, and behaviorally, tantrums, aggression, and fear responses. Luckily, we have the Child PTSD Symptom Scale, or the CPSS-V, that we can use for screening for a PTSD diagnosis and to see the symptom severity. What the CPSS-V uses is child-friendly terminology to describe symptoms, including age-specific functional impairment in settings such as schools, homes, and social life. It uses developmentally appropriate trauma-related distress symptoms, and it goes over all the criteria we've already discussed. A nice thing about the screener is that it has a cutoff score of 31. It can be used for a probable diagnosis of PTSD. You can also specify the severity based on the scoring, from minimal, mild, moderate, severe, and very severe. Now that we've seen what PTSD can look like, I'd like to talk about some evidence-based interventions. So unfortunately, PTSD in children is not a psychiatric diagnosis with a lot of strong evidence for using medications. Most of the evidence exists for trauma-focused therapy. There are a lot of types of therapy out there, including parent management training, parent-child interaction therapy, play therapy, EMDR, several CBTs. However, a recent meta-analysis study in 2024 confirmed that trauma-focused cognitive behavioral therapy, or TFCBT, should continue to be recommended as the first-line treatment for PTSD in children and adolescents. Now, TFCBT has the strongest evidence for effectively treating PTSD in kids in both the short term and the long term. Eye movement desensitization and reprocessing, or EMDR, and all other psychological interventions should ideally be used second line. However, this meta-analysis also demonstrated that any psychological intervention is better than none and will result in a reduction of symptoms. So maybe some of you have had the experience of pediatric patients waiting a long time once a psychotherapy referral is placed to actually start therapy. So what we'd like to do is give you all some tools available to help provide relief to children and their family as they await psychotherapy. Pediatricians play a crucial role in early intervention when a child presents with acute distress symptoms related to trauma. While a referral to trauma-focused care is ideal, brief grounding and stabilization techniques can be used within a standard appointment to help the child self-regulate. These techniques are based on evidence-based trauma-informed care, including some used in TFCBT, mindfulness interventions, and sensory grounding techniques. So the following are effective, time-efficient techniques that pediatricians can implement. They take roughly 2 to 3 minutes to teach, and I'll be going over 3 specific techniques. The first technique is the 5-4-3-2-1 sensory grounding technique or exercise. The purpose of this is to quickly interrupt any dissociation, anxiety, and panic by engaging the 5 senses. You can use this when a child appears overwhelmed, detached, or dysregulated. For example, if you catch them zoning out or hyperventilating. To apply this technique, you can guide the child to name 5 things they can see, 4 things they can touch, 3 things they can hear, 2 things they can smell, if possible, and 1 thing they can taste or imagine tasting. As they list each item, you can encourage them to breathe slowly. Sensory grounding like this has been shown to reduce anxiety and dissociation in children with PTSD. And there's a neuroscientific basis for this. So trauma hyperactivates the amygdala, leading to fear-based reactions. Prefrontal cortex and the somatosensory cortex process external sensory input, which overrides the amygdala-driven fear responses. So these grounding techniques, like 5-4-3-2-1, re-engage the cortex by shifting the child's attention away from the trauma memories or dissociation and towards the present moment through sensory awareness. Also, just like medications, increasing the sensory input can actually increase dopamine and serotonin, ultimately improving emotional regulation and cognitive control. The next technique is the box breathing technique. The purpose of this is to quickly reduce physiological arousal by activating the parasympathetic nervous system. You can use this when a child presents with rapid breathing, tension, fear, or difficulty speaking. You can apply this in around 1 to 2 minutes, and you can do this by coaching the child to breathe in for 4 seconds, hold for 4 seconds, breathe out for 4 seconds, hold for 4 seconds, and then repeat the cycle 3 to 4 times. For the younger kids who are willing to make it fun, you can ask them to trace a square in the air during the exercise. So with your finger, you can go up when you breathe in for 4 seconds, across as you hold, down as you breathe out, and back to complete the square as you hold again. Box breathing is based on the polyvagal theory. Now, the polyvagal theory was developed by Dr. Stephen Porges, and it explains how the autonomic nervous system regulates emotions, safety, and social connections through 3 neural circuits. They include the ventral vagal circuit, which is involved in social engagement, the sympathetic circuit, which is involved in your fight or flight response, and the dorsal vagal circuit, which is involved in shutdown and freeze responses. Trauma can dysregulate the autonomic nervous system, keeping individuals stuck in a hyperarousal state, like anxiety, or a hypoarousal state, such as numbness, making it difficult to feel safe and connected to others. Box breathing, as a controlled breathing technique, can stimulate the vagus nerve, activating the ventral vagal state, or the social connectedness state, which promotes relaxation, emotional regulation, and a sense of safety. In fact, when you exhale, you activate the vagus nerve, slow your heart rate, and increase parasympathetic dominance, also reducing cortisol release. By engaging the parasympathetic nervous system, box breathing helps counteract trauma responses by reducing hyperarousal, calming the mind, and restoring physiological balance. So this practice of box breathing aligns closely with polyvagal theory by using breath control to shift the nervous system from dysregulation to safety and resilience. The final technique we'll go over today is the butterfly hug. The purpose of this is to engage bilateral stimulation to calm the nervous system, similar to practices in EMDR. You can use this when the child is feeling shaky, restless, or distressed. You coach the child to cross their arms over their chest and lightly tap each shoulder, left, right, and breathe in deeply while tapping for about 30 to 60 seconds. So this technique was actually developed for disaster trauma response and has been found effective in pediatric trauma stabilization. The bilateral stimulation facilitates interhemispheric communication, ultimately downregulating the amygdala's fear response. With the self-touch, oxytocin is also released, promoting a calming effect. So how can we implement some of these techniques in a short visit? What you can do is spend 1 to 2 minutes with the stabilization exercise first before discussing some trauma symptoms. You can then normalize the emotional distress, saying something like, lots of kids feel this way after something scary happens. You can reassure the child that they are not alone and that their body or mind can calm down. And you can also involve the parents. For example, task them to coach through a technique before bedtime. Again, it's not expected to do these things during a primary care visit, but they are tools you can give to kids and parents for immediate emotional regulation. So it can be quite overwhelming to treat children who have experienced trauma. So here are some resources that can help. On the national level, we have the National Child Traumatic Stress Network, which offers provider training, trauma treatment guidelines, state-by-state directory of trauma-focused clinicians. We also have the Child Help National Child Abuse Hotline, which offers 24/7 confidential support for children experiencing abuse or trauma. We also have SAMHSA that offers trauma recovery programs, crisis response, and referrals to evidence-based treatment. And locally, we have CPAN for trauma-focused therapy resources and to help you with trauma therapy referrals. CPAN can also be utilized to speak with a child and adolescent psychiatrist in 30 minutes or less regarding diagnostic clarity and treatment planning. And full psychiatric consultations are available for patients at no extra cost to the family. In conclusion, We wanted to talk about trauma symptoms in PTSD and specifically highlight how they may mimic symptoms of ADHD, ODD, anxiety, and depression. It's important to always screen for trauma history before diagnosing a psychiatric disorder in the form of getting a good social history, a good developmental history, and by using some screeners, like we mentioned, the Child PTSD Symptom Scale, or CPSS-V. We also went through some grounding and stabilization techniques, which can be implemented in brief pediatric visits. And we went over some trauma resources for pediatricians, such as the National Child Traumatic Stress Network. And of course, locally, we'd like you to utilize CPAN as much as possible. So our final takeaway is primary care is the first line of defense in identifying and supporting trauma-exposed children, and even short interventions can make a lasting impact. Thank you so much for your time. We can now open up the discussion for any questions.
If you have any questions, feel free to type them in the chat box. There is one in the chat box, a comment for instructions.
Oh, so I see a couple of comments here. Thank you, Dr. Johnson, for sending the link for CPSS-V. That can actually be really helpful for going through the symptoms that we mentioned today. And I see that there's also a comment about a handout with the techniques and instructions. Yes, I can actually put those together in an email and send them forward to have them forwarded out. So there's another comment here saying medication for symptoms of ADHD or mood stabilizers have been useful for me for patients with dysfunction. Yes, absolutely. So the reason why medications are difficult to treat with for PTSD is that, like the differential diagnosis, sometimes we don't know what diagnosis is causing a certain symptoms. So it totally makes sense that a medication may have helped for patients with trauma dysfunction. In fact, the medications with the most evidence for trauma symptoms in kids are actually alpha agonists in these cases. So things like your Intunives, 10X, clonidines, those can be really helpful, especially when we have hyperarousal type of symptoms. A lot of times you can also use medications because you can treat certain symptoms. So if they do have a comorbid major depressive disorder, SSRIs could be useful. If they have nightmares, prazosin could be useful. And just to clarify, the Intuniv and 10X, like Dr. Johnson mentioned, is guanfacine.
Yeah, so obviously medications can be helpful. We just want to make sure that they are getting the appropriate treatment for their trauma. If they don't do the trauma-focused therapy, medication's always going to be a Band-Aid. And yes, we can't control their environment, but we do want to try to get them the right resources, to help be successful as possible. So again, CPAN can help these kids find these trauma therapies, but that's really what they need at the end of the day.
I want to talk a little bit more about the exercises that we spoke about, the grounding techniques, the the stabilization techniques. So you can use those in emergency settings, especially when we're waiting for a therapy referral to go through. And it can be really helpful to teach parents these techniques so that you give them some kind of tool to use when they're in distress at home. Sometimes they might not be showing all the PTSD symptoms in the office here with you because it's such a controlled environment, but at home, you always hear some horror stories from the parents. So these grounding techniques, one, everyone can help from it because it can help regulate our own emotional system. And it can also help with having a tool to be able to do something rather than feeling helpless about some of the tantrums or hyperarousal behaviors that you're seeing at home. One thing that's really helpful when teaching both the child and the parent these techniques is that when you can teach them to do these things together, children can feel connected to their present moment and with their caregiver themselves. The very act of feeling connected with your caregiver and doing a technique at the same time can do something to the brain to help calm those nerves down, especially doing a simultaneous activity in coordination with another person. There are several other techniques that are out there, and a lot of them have to do with being in synchrony with somebody else, which can help you remember where you are rather than being dissociating or having a flashback to a traumatic memory.
Yes. Yeah, well, the question was, can we discuss kind of parents who really, really, really want the medication and don't want to get them the therapies and things that they need. Um, that's a hard one. Someone I struggle with. But a lot of times I do have to have the conversation with parents that, there is not a medication for PTSD. We're kind of using everything off label. If we get a 30% reduction in symptoms, that's probably pretty successful with medication. So I just keep emphasizing kind of over and over that, this really isn't a medication problem. At the end of the day, trauma has kind of changed their brain and how they react and how they, associate with people, their peers. And so we really need the therapy to essentially rewire their brain to kind of give them the best chance at, getting these symptoms in remission, especially as they get older. So I just kind of keep reemphasizing that, again, medications, really a Band-Aid when the primary problem is PTSD. Again, a 30% reduction maybe is successful. We can't expect that medication is going to fix all of this. And so, again, really just emphasizing that trauma-focused therapy is the primary evidence-based treatment here, has been shown over and over again in the long term to help with these symptoms and reduce them the most.
These are all great questions because it leads to a lot of common things that we experience in the office here. And one thing I would like to recommend is a book called The Body Keeps the Score. This is a book that I'm sure many of y'all have heard of before, but it's by Dr. Vanderkolk. And he is a Harvard-trained psychiatrist who's ultimately the expert in trauma and helped actually start the National Child Traumatic Stress Network that I mentioned earlier. Now, this book dives really into a lot of the neuroscience behind traumatic events, how traumatic events can change people's emotional dysregulation, and offers a lot of therapeutic modalities that actually can help treat trauma. It also has some very enticing patient stories that will leave you pretty shocked, and how they were able to be healed by certain therapeutic modalities, which is even more shocking. So although medications are not always the best fit for treating PTSD, the book really shows a lot of hope in terms of that there are treatments to help heal people from PTSD and even cure. So please check out that book, The Body Keeps the Score. It's really insightful. It goes really deep, and it's really good at a clinician level. I think all clinicians who are interested in trauma or treat anyone who suffer from trauma would benefit from this read.
Does anyone have any other questions? Feel free to type them in the chat box. And don't forget to scan the QR codes. The Cloud CME code for physicians, that CME code is for nursing credit. Right. Thank you very much. We appreciate your attendance, and we certainly appreciate the excellent presentation.
Thank you all for your time.
Thank you.